So my name is Denise Hall Burton, and I'm one of the anesthesiologists at Children's Hospital of Pittsburgh of UPMC. I'm going to be talking today about local anesthetics. I have nothing to disclose. Specifically, we're going to talk about uptake, biotransformation, excretion, comparison of different drugs and their chemical groups, prolongation of action, side effects, toxicity, as well as intralipid for local anesthetic toxicity. So one of the things I think is interesting is that if you look back in 1900, this gentleman in the Annals of Surgery was talking about the importance, the potential importance of local anesthetics, which is evident in this quote here, where he saw a possibility of different cases in the future being able to be done just with local anesthetics. So the history of local anesthetics I find a bit interesting. 1850, cocaine was extracted by the coca bush, and then in 84, so a bit of a gap there, you have Sigmund Freud and Kohler who used it for an eye procedure. And then in 1904, procaine, which is an ester, was synthesized, and that's a synthetic cocaine. And then in 1993, tetracaine was developed. That was more potent than procaine. And then in 1943, you have the development of lidocaine, which was really a bit of a game changer, a nice shorter acting medication that we could use. And it's not until 57 that we have bupivacaine, which was synthesized, and then quite a big gap until we had more advancement of these medications with ropivacaine, which was introduced to the market in 96. So how do these local anesthetics work? So this is just an image here to send you back to medical school. And at some point, I think you should review this. In the interest of time, I'm going to skip over this for now. But the main points are that the nerves transmit sensation as a result of the propagation of electrical impulses. And that propagation is accomplished by alternating the ion gradient across the nerve cell wall or the axonema. So those are the two important things to get from a review of how the resting potentials work and the nerves work. So local anesthetics block the voltage-gated sodium channels and they interrupt initiation and propagation of those impulses in axons. So that's how our local anesthetics are going to be functioning primarily. So let's talk a little bit about the different parts of a local anesthetic, and this will take you back to a little bit of chemistry, which I always think is a good bit of fun. So there are three main different parts of the local anesthetic. You have the aromatic portion, an intermediate chain, and then the amine group. And the aromatic portion is lipophilic. The intermediate chain is where you're going to have a differentiation between whether the local anesthetic is an ester or an amide, and then the amine group, which is the hydrophilic group. It's important to know that these local anesthetics are weak bases and they exist in an ionized and unionized form. And this next slide here is an important one because this is prime for lots of information for your exam. Protein binding is equal to duration of action, the pKa is equal to the speed of the onset, and lipophilicity is proportional to potency. And we'll talk about each of these things next. So protein binding. So protein binding determines the duration of action. Local anesthetics with greater protein binding have greater attraction for the receptor sites, and they remain within the sodium channel for a longer period of time. And so that's how protein binding helps to determine the duration of action of the local anesthetic, as I mentioned before. So lipophilicity, it's proportional to potency, and local anesthetics with greater lipophilicity are more easily penetrate the nerve cell membranes to become intracellular. And so lipophilicity, as I mentioned, is proportional to potency. And then pKa. So what is pKa? This is something that a lot of people usually have to go back and look over again. So the pKa defines the pH at which the ionized or charged form is going to be equal to the unionized or the uncharged form. So as the pH of the substance changes, the percent of the ionized versus the unionized changes as well, and that's based upon that substance's pKa. So the pKa determines the amount that exists in the ionized form at a given pH. And at physiologic pH, all local anesthetics are in an ionized form greater than an unionized form. So lidocaine, for example, has a pKa of 7.9, and 25% of that is going to be in an unionized form. Bupivacaine and ropivacaine, for example, have a pKa that's higher than lidocaine. It's 8.1. and about 15% of those local anesthetics at physiologic pH will exist in an unionized form. So, why is this important? Well, the unionized form enters the cell faster. So the lower the pKa, the greater the percent of the unionized form, and the faster the onset. So why don't local anesthetics work as well in infected tissues? So different choices here: decreased blood supply, inflammatory mediators causing changes in alpha subunits of the sodium channel, increased percent of local anesthetic in unionized form leading to a delayed and reduced effect, or the pH is lower. And the answer to this question is D, that the pH in infected tissues is lower, and so they're not going to work as well. It's going to change the pH. It's not going to be in an ionized as opposed to unionized form in the same percentages, and so it won't work as well. The other issue with this is that many times in infected tissues you have an increase in blood supply, which is going to take some of your local anesthetic away from the site where you're hoping to have its action. So let's talk a bit about the types of local anesthetics, and there are two main classes of local anesthetics: esters and amides. So esters are metabolized quickly by hydrolysis, and specifically that's pseudocholinesterases. Their metabolic product includes PABA, which is important, PABA, because that increases the likelihood for an allergic reaction. Although it's still a low risk, it does increase the likelihood as compared to amides. And their metabolite is excreted renally. One exception, however, to metabolism is cocaine, which is hydrolyzed by the liver. And amides are metabolized in the liver by dealkylation, and then hydrolysis via the P450 system. And this is important to know because if you have other medications that a patient is on that is using or modifying the P450 system in terms of increasing the metabolic rate or decreasing the metabolic rate, that's going to affect the metabolism of your amide. So an exception to this would be prilocaine, which is metabolized in the liver, the lung, and the kidney. These local anesthetics, amides, have less allergic potential. They're bound to plasma proteins mostly. They also bind to alpha-1 acid glycoprotein, which is one of the plasma proteins. And it is important to know that in neonates and infants less than 6 months of age, the percent of that particular protein is lower, so they have less binding. And their metabolic excretion for the amides is renal as well. So here's a chart of some different esters. You have cocaine, procaine, chloroprocaine, and tetracaine. Gives an example of their duration of action with epinephrine and without, as well as the max dosing, both with epinephrine and without. And you can see that there is a pretty broad range in the duration of action for these local anesthetics, these esters. So the next chart I have here is of amides, and a good little hint is that amides have two eyes. So if you're trying to determine which one is an amide, look for the one with two eyes, and that should be your amide. And these range from lidocaine to ropivacaine, bupivacaine, prilocaine, and I have here listed their duration of action with and without epi, as well as max dosing. So, which local anesthetic is more likely to affect a fetus? Let's move on to a question. So, chloroprocaine, ropivacaine, or lidocaine, or none of the above? So, esters are metabolized very quickly, as we said before, with pseudocholinesterases. So, very little is left to even cross the placenta. So, we can mark the esters off of this list. Of the amides, those with less protein binding, like lidocaine, are more likely to cross the placenta. So those are ones that are going to be more likely to cause a problem for a fetus. So if the fetus also becomes acidotic, there can be ion trapping, which is important to note. So more fetal local anesthetic is in the ionized form in an acidotic fetus, and it's unable to cross back to the maternal circulation. So additives. Let's move on to different additives that are commonly included in local